to the doctor, we hope that the care we receive is based on flawless, unbiased medicine. But what if the science is wrong? What if the evidence-based medicine our doctors are taught is based on flawed evidence which only accounts for less than half of our population? In 1991, a woman called Dr. Bernadine Healy released a paper highlighting the different presentations of heart attacks in males and females. This paper, a part of her Women's Health Initiative, was a long-awaited turning point in women's health research. For so long, the quality of healthcare delivered to women has been hampered by a lack of knowledge surrounding sex and gender differences in common conditions and their treatments. Today, I'm going to outline the main ways in which sex and gender difference affect women today, and clinical trials, healthcare, and research are failing women by examining a few conditions more closely. I'll start by looking at coronary heart disease, the leading cause of death for females in 2019. Patients with coronary heart disease are at a significantly greater risk of experiencing acute cardiac events, for example, heart attacks. Heart attacks can be detected in lots of ways, including symptom recognition and blood tests to check the levels of specific biomarkers. In terms of the symptoms of a heart attack, we now know that while chest pain is the most common symptom for both males and females, females are more likely to experience atypical symptoms such as nausea and jaw pain. Due to the subjective nature of symptom recognition, doctors often turn to the numbers to rule out a heart attack. When it comes to testing the levels of heart attack biomarkers such as troponin, research has shown that the use of sex-specific thresholds, rather than the same threshold for males and females, can double the rate of heart attack diagnosis in females. In terms of gender differences in heart attacks, a 2018 retrospective study of post-heart attack mortality rates in Florida has shown that when comparing patient-doctor gender concordance, female patients treated by male doctors are less likely to survive than males treated by males, males treated by females, and females treated by females. Interestingly, the study found that this difference did not happen when the gender roles were reversed, i.e., mortality rates were very similar for all patients treated by female doctors, whether they be male or female. Fortunately, we won't have to deal with the logistical nightmare of stopping male doctors from treating female patients, because the study also found that female patients had better outcomes if their male doctors simply had more exposure to female patients and female colleagues. There are also differences when it comes to the drugs used to treat heart conditions. Statins are a type of drug commonly used in the prevention of cardiovascular disease. In a large group of American patients with or at high risk of developing cardiovascular disease in 2015, it was found that females who are eligible for statins are significantly less likely than males to be prescribed them. This, along with the underprescription of other drugs, such as aspirin and beta blockers, is due to a combination of factors. The first is that females are less likely than males to present with what's known as obstructive coronary artery disease, which means there's often no obvious obstruction for doctors to see when looking at angiograms. However, this physiological difference alone cannot be the sole reason for these differences in prescription, because even when females presented with an obvious obstruction, they were still less likely to be treated with statins, aspirin, and beta blockers. The 2015 study suggests that this could be because females are less likely than males to think that statins are safe and effective. We can infer from this study that in order to minimize these differences, we must not only find more reliable methods of detecting non-obstructive coronary artery disease, but also ensure that female patients are provided with adequate resources and knowledge about the safety and effectiveness of drugs like statins. Quite frankly, it is unsurprising that females do not always trust that the drugs they are prescribed will be safe and effective at treating their condition. The thalidomide scandal in the 1960s, in which 10,000 children were left seriously disabled, and the DES scandal in the 70s, in which up to 10 million women were prescribed a drug which significantly increased the risk of their daughters developing reproductive issues, breast, womb, and cervical cancer, are all too recent. their impact was not only horrific for those suffering the direct consequences, but has also had a long-lasting impact on the world of clinical trials and research. As a result of these disasters and others, in 1977, the FDA recommended that all females of childbearing potential be excluded from participating in clinical trials. Now, while this might have provided protection for females and fetuses at the time, it certainly hasn't helped females today. We are now effectively having to play catch-up with our research into how different conditions affect females and whether this is different to how they affect males. Another condition affected by sex and gender differences is Alzheimer's disease. Around 2/3 of people with Alzheimer's disease are women, but the tests used to diagnose the disease often do not detect it in its early stages in females. This is because throughout their lives, the verbal memory of females is actually better than that of males. Therefore, they are able to pass the verbal diagnostic tests even with Alzheimer's. This is a problem because by the time they've been diagnosed, they've missed out on early interventions and they deteriorate rapidly. Autism spectrum disorder, or ASD, is another example of where male-biased criteria can delay diagnosis in females. Studies have shown that a combination of the underreporting of autistic traits in female students by their teachers, a tendency for females to internalize problems rather than expressing them externally through hyperactivity, and the increased effort that females with ASD make to socialize and form traditional friendships is what leads to the late diagnosis of ASD in females. Unfortunately, even for those conditions where we have discovered a great deal about sex and gender differences, there are still so many barriers to break down before we will be able to see the results of this research being translated into the real-life diagnosis and treatment of these conditions. For example, although 70% of people with rheumatoid arthritis are females, only 7% of the National Institutes of Health annual budget for rheumatoid arthritis goes towards female-focused research. This is a problem because female-focused research is imperative if we hope to understand how all conditions affect females to the same extent as we understand how they affect males. Lack of funding is not the only thing holding sex and gender difference research back. One major hurdle which we must overcome if sex and gender difference research is to reach its full potential was discovered by a study published in the Journal of Women's Health in 2021. This study sent out slightly different versions of a research abstract to just under 18,000 people. The only way in which these abstracts differed was whether the subjects of the study mentioned were described as individuals, males, or females. The results were clear. While most felt the female research to be more impactful, the male abstract was almost twice as likely to be recommended for publishing than the female abstract. This is obviously hugely problematic. One might ask themselves, how can we expect to advance our understanding of women's health when there is such a publication bias? Well, there is hope. That hope is driven and inspired by patient advocacy. For female patients, it can be as simple as asking your doctor about the side effects of a prescribed drug in females, or making a list of detailed questions to ask your doctor before attending an appointment. For those supporting their female friends and family, you can advocate for them when they're unable to do so themselves, or even write to your MP to demand more funding into how specific conditions affect females. For everyone, no matter which gender, you can continue to educate yourself on this topic by attending talks just like this one. These actions can go a long way to help fight everyday gender inequalities in healthcare. But in order to reach true equality, scientists and policymakers must engage with this topic and keep it at the forefront when conducting research and creating new healthcare guidelines. Some organizations are leading by example. In 1993, 2 years after Dr. Healy launched the Women's Health Initiative, a law was passed in the USA which required all trials funded by the National Institutes of Health to include women. While this does still leave the potential for an extremely small proportion of participants to be female, it is still a step towards understanding, a step towards evidence-based medicine for all genders, a step towards equality for women's healthcare. Thank you.